Welcome to this session of the Center for Podiatric Education. In this session, I'd like to speak about a subject that is a very difficult clinical problem and unfortunately is a subject that is frequently involved in litigation, and that is the subject of complex regional pain syndrome. I can tell you that in my 40 years of practice, I have had occasion to participate in the diagnosis and treatment of a number of patients with complex regional pain syndrome, and also to participate in work as an expert witness in lawsuits involving complex regional pain syndrome. This is a very difficult clinical problem and frequently is associated with litigation. The history of complex regional pain syndrome begins with the surgeon Claude Bernard. Most individuals seem to attribute the elucidation, if you will, of complex regional pain syndrome to Silas Weir Mitchell during the Civil War, who seems to have described this entity in significant detail, primarily associated with war-related injuries. Mitchell did set up an infirmary for neurologic disorders in Philadelphia. This is a photograph of Dr. Mitchell at that infirmary for quite some time. This was, in fact, a certificate of disability for a patient with complex regional pain syndrome who had sustained a gunshot wound to the left foot. I have a friend who likes to say that complex regional pain syndrome can be best defined as the best way to spend more time with your malpractice attorney. Leaving for a second the issue of evaluation of care and care of patients, but looking at the reality of complex regional pain syndrome, again, I participated in an unbelievable number of lawsuits involving complex regional pain syndrome, and they've really ranged from major reconstructive procedures to actually things such as ankle sprains and even the excision of plantar warts. When litigation evolves with regard to complex regional pain syndrome, the allegations generally are in one of four areas. The first is a failure to diagnose the complex regional pain syndrome, and this, of course, is alleged to lead to a delay in appropriate treatment, and the general philosophy that the longer one goes with complex regional pain syndrome untreated, the more difficult it can be to manage. The second is failure to refer the patient once the signs and symptoms of complex regional pain syndrome are evident. Failure to treat adequately the complex regional pain syndrome. And this is a problem primarily when, again, there's a failure to refer, because in general the podiatric physician is not going to treat complex regional pain syndrome independently. The more important issue, I think, is the allegation that the complex regional pain syndrome resulted from an unnecessary procedure. Typically, it'll be an invasive procedure, that the patient developed complex regional pain syndrome, and that the procedure was unnecessary. In thinking over my experience with complex regional pain syndrome cases, I would say that the majority, certainly not all of them, but the majority tended to be associated with surgical procedures on peripheral nerves, such as Morton's neuroma excision, tarsal tunnel excisions, decompression of superficial and deep nerves, period. But again, I've seen complex regional pain syndrome associated with first MPJ surgery and even with the excision of plantar warts, so that one never knows in what patient a well-meaning, well-intended, indicated procedure can result in complex regional pain syndrome. The problem is that of chronic refractory pain. Generally, the patient has debilitating symptoms and signs that are unresponsive to treatment, and more often than not, once it's recognized, referral to a pain clinic or neurology or physiatry is indicated. And you could see in this photograph the typical presentation of complex regional pain syndrome in the lower extremity. We generally have edema involving the foot and leg. And in my experience, as evidenced in this particular photograph, the foot is typically held in equino varus, and I found that to be a rather typical presentation. The bigger problem is that it can occur in the post-operative patient or the patient who has sustained trauma. And here again, we're treating the patient for their initial injury. They're complaining of pain and swelling. We attribute this to the typical findings we may see associated with that injury. And then in hindsight, someone determines that the patient had complex regional pain syndrome and that the signs and symptoms that we had been evaluating were not related to the initial injury, but were actually complex regional pain syndrome. And typically this is, in my experience, hindsight bias. A lot of these cases, there's litigation involved of some type, not infrequently workers' compensation. And again, in my personal experience, these patients seem to be rather passive-aggressive and seem to want to blame somebody for their current fate. There have been changes in the definition of complex regional pain syndrome over the years. When I started practice, we typically refer to this as reflex sympathetic dystrophy syndrome. Some people continue to use that term. Others feel that since it is not a reflex, and since at times the patients may have a paucity of sympathetic nervous system associated signs and symptoms, that the term complex regional pain syndrome is more appropriate. Generally, the term is used to describe these patients that have continuing pain, which can either be spontaneous or can be evoked by provocative testing. The definition has also changed somewhat in that the term has been expanded not only to disproportionate degree of pain, but now disproportionate length of time during which the patient experiences that pain. It is typically distal in presentation, at least initially, and we see quite a bit of change suggestive of some involvement of the autonomic nervous system and sensory nervous system and motor nervous system. So we variously see vasomotor changes, eventually trophic changes, and sensory changes. The typical history is some type of initiating event or immobilization. This can be trauma, it can be surgery, it can be an injection, it can be excision of a cutaneous lesion. There is a percentage of patients that have the onset of complex regional pain syndrome without any apparent initiating injury or trauma. This is a bit more common in female than male patients. So the patient has some initial inciting event. They have continuing disproportionate pain. They have allodynia, which of course is the fact that they experience pain in response to stimuli, which are typically not painful, such as simply touching the foot. They have hyperalgesia, meaning that painful stimuli are perceived and reported as being even more painful than normal. Edema is now considered a major component of complex regional pain syndrome, vasomotor changes, and the fact that, and this is critical, that the patient has no other likely diagnosis. And this is very, very important. Oftentimes, patients develop complex regional pain syndrome after a surgical procedure or an injury. And they may have, for example, a non-union. They may have an arthritic joint. They may have scar tissue about a nerve. And even though they are having significant pain, that pain may very well be related to an explainable etiology. So that it is important to understand that when we classify a patient as having complex regional pain syndrome, we are saying that there is absent any other reasonable explanation for their symptoms. And this is a very, very important component of the diagnosis. Typically, working up patients with complex regional pain syndrome, the first, obviously, is a suspicion that the entity exists. The diagnosis is primarily clinical. X-rays may be of no benefit, particularly early on in the course of this disorder. After several weeks, we may begin to develop osteopenia, which may be due to the disorder itself or may be due to disuse. If we suspect complex regional pain syndrome, probably radionuclide imaging with technetium represents the most sensitive test early on, being positive in about 44% of patients. The differential diagnosis is, again, number one, whether or not there is another explainable cause for the patient's symptomatology. And if there is, this would eliminate or mitigate the diagnosis of complex regional pain syndrome. Polyarticular gouty arthritis or other inflammatory arthritis. This can include transient regional osteopenia, infection or infectious osteoarthritis. DVT can be in your differential diagnosis, and in fact, of patients who have non-traumatic onset of complex regional pain syndrome, deep vein thrombophlebitis, as well as stroke, spinal cord injury, these are other potential etiologies for complex regional pain syndrome. Compartment syndromes and acute ischemia can result in signs and symptoms that are similar to complex regional pain syndrome. Charcot's joint disease, and although we typically think of this as being non-painful, there are some occasional patients that do develop complex regional pain syndrome, like symptoms associated with Charcot's joint disease, and as I mentioned, transient regional osteoporosis. There is a general classification of complex regional pain syndrome into two major types. Type 1 was formerly known as Sudeck's atrophy, algoneurodystrophy, meaning painful neurodystrophy. This is probably the most common, and in these patients, there is no demonstrable nerve lesion. Type 2 complex regional pain syndrome has frequently been referred to in the past as causalgia. These are patients that have a significant burning component to their symptoms and have an identifiable nerve lesion. This tends to be actually more painful than complex regional pain syndrome, and causalgia can be much more difficult to control. When we discuss patients with neurologic problems, such as complex regional pain syndrome, we want to make certain that we utilize our adjectives and descriptive terms appropriately. We want to remember that hyperalgesia, when we use that term, we're talking about increased pain from a stimulus that does in fact normally provoke pain, so that something like pinprick or pinching elicits more pain than typical. Paresthesia, referring to abnormal sensations. Dysesthesia, referring to unpleasant sensations. Hyperesthesia, meaning increased sensitivity to stimulation. And so we want to make sure that we use these terms appropriately. In general, I believe in today's world, we're getting away from staging complex regional pain syndrome. However, many individuals continue to stage complex regional pain syndrome. From a clinical standpoint, it is somewhat important. During the acute stage, which occurs immediately following the injury, the limb is swollen and red, and there's a burning paresthesia or dysesthesia reported. There's increased sweating of the affected limb, and the symptoms and signs tend to stay localized to the area of injury. It's important to recognize this stage because at this stage, the acute stage, if you will, the foot is vasodilated, and oftentimes therapies which are directed at vasoconstriction or therapies that have a vasoconstrictive property, for example, the use of steroids, seem to be more effective during the acute phase. The second phase occurs within months. There's no absolute time as to the transition from acute stage to stage 2 or the dystrophic phase. During this phase, the limb becomes cooler, the sweating continues, we begin to see osteoporotic changes on X-ray, and the pain occurs more generally, not just restricted to the more distal area of the incision. Now, this is important again for several reasons. If we suspect complex regional pain syndrome is in the dystrophic phase or stage 2, then oftentimes we may want to include therapies that are vasodilatory rather than vasoconstrictive. We may also want to employ therapies that are helpful in treating osteoporosis, perhaps a calcitonin or some other agent, maybe a Fosamax, perhaps an intravenous infusion of a bisphosphonate. So the staging is important not only for documentation, but oftentimes in helping us to determine the appropriate therapy. The last stage is the atrophic stage, and unfortunately, this can go on for years following the injury. The atrophic stage is one in which we have disuse atrophy of muscle, we have muscle and tendon and soft tissue contractures. The pain becomes constant, and we have vasomotor and pseudomotor changes, including skin that becomes atrophic, pale, thin, and shiny. The etiology of complex regional pain syndrome remains something of a debate. It is certainly possible that the clinical manifestations of complex regional pain syndrome represent a common pathway for potential multiple etiologies. And as you can see, a variety of etiologic factors and explanations have been proposed for the origin of the complex regional pain syndrome. Some of these are based on findings that may be the result rather than the cause of the complex regional pain syndrome. So in some patients, there may be a benefit to utilizing anti-inflammatory therapies. In others, there may be some benefit to the use of peripheral nerve blocking agents such as local anesthetic blocks or transcutaneous nerve stimulators. In some patients, psychotherapy may be of benefit. But as you can see, there have been a variety of pathophysiologic mechanisms proposed, and really, when all is said and done, it's likely that more than one mechanism is present in any individual patient. We know that the diagnosis of complex regional pain syndrome is clinical. And so the question is, are there criteria that one can utilize to make the diagnosis? And there are generally 3 accepted standards for clinical evaluation and diagnosis of complex regional pain syndrome. One of the more popular is the Budapest criteria. And that has four basic components. Number one, the patient has disproportionate pain continuing after some initial event. Number two, that the patient has at least one sign in two or more of the categories listed in front of you. Number three, that the patient reports at least one symptom in three or more of the categories listed below. And again, importantly, that no other diagnosis can better explain the signs and symptoms. So here again, we may have a patient with a symptomatic non-union, which could explain the signs and symptoms rather than just simply attributing this to complex regional pain syndrome. And this is very important because when a patient's diagnosed with complex regional pain syndrome, there's generally a reluctance to perform invasive procedures. And some of these patients may have a correctable problem. So looking at the categories for signs and symptoms, the patient should have at least one sign in two or more of these categories. So that would include allodynia or hyperalgesia. We may have edema. We may have sweating changes, typically diaphoresis, but it may be later on a decreased sweating. The presence of contracture of joints, decreased range of motion, tremor, dystonia may be manifestations of complex regional pain syndrome. The patient should have at least one symptom in three or more of the categories, those symptoms including hyperesthesia, and again, temperature asymmetry or differential, observed sweating, asymmetry and or swelling, and decreased range of motion. The International Association for the Study of Pain also has its criteria for the diagnosis of complex regional pain syndrome, type 1 as well as type 2, which again was formerly known as causalgia. To diagnose causalgia, all three components must be present. That includes continuing pain with allodynia or hyperalgesia after an identifiable nerve injury. For example, it may have been a contusion, a laceration. It may be a Morton's neuroma excision or a tarsal tunnel excision. There should be evidence that there was in fact edema with increased or decreased blood flow and abnormalities in pseudomotor activity, meaning abnormalities in sweat function. And again, importantly, the fact that if there's another explainable reason for this person's pain, that this excludes the diagnosis of complex regional pain syndrome. As far as complex regional pain syndrome type 1 goes, again, a history of some initiating event or a history of immobilization, continuing pain, allodynia, or hyperalgesia, which is disproportionate to that inciting event, evidence of edema, changes in skin flow, changes in sweat function, and once again, the fact that the diagnosis is excluded if there is the presence of an alternative diagnosis. I think development criteria is probably the least used, and it really is reflective of the International Association for the Study of Pain and for the Budapest criteria in order to diagnose complex regional pain syndrome type 1. 4 of the 5 following should be present. Again, unexplained diffuse pain, differences in skin color, meaning that we are talking about autonomic nervous system associated changes. Once again, diffuse edema, difference in temperature due to vasomotor changes, and limited range of motion. There should be the occurrence of the signs and symptoms with or following use of the extremity, and that the signs and symptoms are found in an area well beyond that of the initial injury. So I guess in summary what I'm saying is that in support of the diagnosis, one might wish to employ either the criteria inherent or a part of the Budapest criteria or the International Association for the Study of Pain. In any event, regardless of the criteria utilized, whether it's Veltman or International Association for the Study of Pain or the Budapest criteria, pain is the sine qua non for diagnosis, and either the pain is going to be disproportionate to the injury or it's going to be extending for a longer period of time. Once again, it is very important to remember that this is absent alternative diagnoses which could explain those signs and symptoms. The majority of patients have pain even at rest without moving the extremity. They typically describe the pain in any number of ways, most commonly as a burning pain. And you could see such a patient that we're trying to examine, and they reject you even lightly touching their foot with their hand. Allodynia, meaning the elicitation of pain from non-painful stimuli, in this case just trying to use a cotton tip. As far as the sensitivity and reliability of the criteria that we discussed, the International Association for the Study of Pain criteria has anywhere from an 89 to 100% sensitivity and has a 36 to 55% specificity. And here again, the problem is that we may have alternative diagnoses because, after all, the complex regional pain syndrome is typically initiated by some type of injury or some event. And that alone could explain the continuing signs and symptoms. Typically, complex regional pain syndrome patients describe their pain as being severe, much worse than most of the typical pain that we have described to us by patients for other etiologies. Edema is a major part of the diagnosis. We hope that if a patient does have complex regional pain syndrome, that we are able to physically observe that edema, or at least have a good description of the edema. Typically, this involves the foot and the leg. We see vasomotor changes, and again, this patient with typical equinovarus presentation that we see, and you can see in the left lower extremity, bluish discoloration, which is unilateral in nature. Obviously, you want to exclude entities such as compartment syndromes, acute ischemia, patients with inflammatory rheumatic disorders. But when all is said and done, this is a rather typical presentation for patients who have the vasomotor component. This supinated inverted position is very, very common in patients with complex regional pain syndrome. Again, the edema of the leg and the foot with tight, shiny skin. You can see the difference in coloration reflective of the vasomotor changes present in the patient with complex regional pain syndrome. Rather severe edema with vasomotor changes in a patient with complex regional pain syndrome. If we look at the presenting signs and symptoms typically seen in stage 1, the patients are complaining of pain. We see skin discoloration, we see temperature changes, edema, and limited active range of motion of that foot. This was one of my patients with complex regional pain syndrome, demonstrating many of these components. One of the reasons the name was changed to complex regional pain syndrome rather than reflex dystrophy is illustrated here, and that is day to day, week to week, and month to month, the manifestations can change, so that we can have varying levels of pain from day to day, and also varying levels of the sympathetic component. So on one day we may see a patient that has really less pain and less of a sympathetic component. On other days, more pain and more sympathetic components to their manifestation, and on other days perhaps some intermediate presentation. And this is the reason that the term was changed, so that we may see different presenting clinical manifestations when we see the same patient on varying visits to the office. What about x-rays? Obviously, we frequently are taking x-rays to evaluate the initial injury or trauma that occurred. X-rays have a sensitivity of about 60% for evaluation of complex regional pain syndrome, but they are non-specific. And in general, we see initially at least diffuse osteopenia with juxta-articular bone changes typically occurring somewhere between 2 weeks and 4 weeks with soft tissue swelling. So if we look at these x-rays here, we get a feeling for some diffuse osteopenia with osteopenic changes in the mid-tarsal area and juxta-articular osteopenic changes here at the metatarsal phalangeal joints. And these are rather typical changes that we see with complex regional pain syndrome. This was a patient that we had evaluated in the office, was under orthopedic care for an injury. The orthopedic doctor failed to make the appropriate diagnosis. The patient had, at the time we saw them, rather obvious complex regional pain syndrome. This started with a contusion to the foot. Here's the initial x-ray. This was an x-ray about 6 weeks later, and this was the patient's x-ray about 12 weeks later. This is the time that we had the opportunity to evaluate the patient. And this patient was demonstrating rather classic changes, as you could see, of complex regional pain syndrome with juxta-articular osteopenic changes. And if you didn't know better, you'd probably suspect this patient had some type of inflammatory rheumatic disorder, maybe rheumatoid arthritis or some such thing, but in fact, it was a patient who had complex regional pain syndrome. We've heard the term Sudeck's atrophy, and Sudeck's atrophy refers to the rather extensive osteopenic changes that can occur in the patient with complex regional pain syndrome. It is not present in the majority of patients, but extensive osteopenic changes, as in this patient, can occur. If you suspect complex regional pain syndrome early on, probably your best study to order is a 3-phase radionuclide imaging. It is very sensitive. We have, of course, the immediate post-injection film, and then the delayed image, the venous pools, which are probably the most sensitive part of the test. We see that just as the x-rays showed juxta-articular changes, we typically see juxta-articular changes on the bone scan at the metatarsal phalangeal joints, certainly a differential scan when compared to the contralateral foot, and typically we see some diffuse uptake in the midfoot. And again, if you think about the x-rays that you just looked at, the bone scan is fairly reflective of this. The immediate post-injection film, so-called radionuclide angiogram, is abnormal in about 40% of patients, and the blood pool image in 50% of the patients. So delayed imaging really is where we see the most obvious changes consistent with complex regional pain syndrome. In other patients, we see diffused uptake throughout the foot, but typically, again, this juxta-articular accumulation is the most typical presenting pattern that we see. Unfortunately, we don't have a way to look at radionuclide imaging and predict patient response, although it has been suggested by some that if you have this particular scanning pattern in front of you, that the patient is more likely to respond to corticosteroid therapy. In some patients, we see diffuse non-focal uptake on the delayed imaging. Probably one of the most underutilized modalities for the diagnosis of complex regional pain syndrome, and probably a number of other entities, is that of thermography. At least in theory, thermography offers us tremendous potential benefits for really a variety of pathologic conditions that we treat. It is not readily available, and certainly high-quality thermographic studies are not readily accessible to many. It is, however, a reliable tool for the diagnosis. You want to remember the reason that the name was changed, and that is not all patients do have vasomotor instability. And you're not going to diagnose complex regional pain syndrome just by thermographic evaluation. However, differential temperature findings on these studies certainly are consistent with complex regional pain syndrome and can be incorporated into your overall evaluation of the patient. You want to make sure that you're not seeing the effects of other factors when you do thermographic studies, such as the effect of smoking or recent physical activity and so forth. But you will get a differential scanning of the feet with thermography, and depending on the stage, you will either see significantly increased temperature or significantly decreased temperature of that patient. Typically, you want to achieve equilibrium. The thermography study should be done with appropriate environmental control. You want to advise the patient to wear loose-fitting clothing. They should be accommodated in a hospital gown for about 20 minutes, and bilateral images are taken. And this can be combined with autonomic reflex testing. This is the Jacobs autonomic neuropathic study technique. You simply take the patient's feet and place them first in a pan of cold water, then in a pan of warm water, and you simply look at the color changes in the 2 feet. You would expect that if the nerve supply, particularly the autonomic nerve supply, were equal, that both feet would have the same presentation in terms of color. So while I can't use this to quantitate, again, what I can do is use this to support my suggestion or my thoughts that the patient has some problem with their autonomic nervous system in one leg or foot, and this is reflected by a different change in response to cold and warm weather. MRI is rarely utilized. One can see soft tissue thickening. One can see, again, juxta-articular osteopenic changes, and one can see subperiosteal and subendosteal bone reabsorption and scalloping. So while this is a more expensive way to go, MRI can be utilized for the diagnosis of complex regional pain syndrome. There are established MRI changes, but this is a modality that's typically not utilized. In looking at the patient with causalgia, that is type 2 complex regional pain syndrome, we do want to attempt to identify the nerve that is involved. The problem is we're dealing with a patient who is hyperesthetic, who's suffering from allodynia very frequently, and so this makes the performance of an electrodiagnostic test very difficult in many of these patients. It is helpful in the sense that it can be used to identify focal nerve lesions and can be utilized, therefore, to identify potentially treatable lesions. But this is not an easy test to perform in the patient with allodynia and hyperalgesia. So we've made our diagnosis of complex regional pain syndrome. We've utilized appropriate criteria, be it Budapest criteria or International Association for Study of Pain or the Veldman criteria. We've gotten appropriate confirmatory radiographic or radionuclide or MRI or thermographic studies, and we're now ready to participate in the treatment of the patient. And generally, the treatment of complex regional pain syndrome is going to fall under the province of the physiatrist or neurologist or pain management specialist. And this could be quite complex. The patient clearly requires pain relief. They require physical therapy and vocational training and rehabilitation. Oftentimes, we require various psychological interventions, and a great deal of education to the patient is required. So we want to optimize oral analgesia. We frequently can utilize topical analgesics, again, if the patient can tolerate the application of the medications. This can occur, this can also include the use of TENS units. We want to try to encourage the patient to move the extremity. In that regard, we may participate with physical therapy. For example, I've had patients that will come to the office for peripheral nerve blocks, following which they undergo physical therapy. I've had patients on whom I have performed beer blocks, following which the patients go to physical therapy. Referral typically includes referral to a healthcare provider that can provide sympathetic nerve blockade, not only for diagnostic purposes, but also for hopefully relief of pain and interdiction of the vasomotor and pseudomotor changes. Not infrequently, evaluation by psychiatry or psychology or social services is required. How one proceeds beyond this depends on many factors, number one of which, of course, is patient response, whether the patient does well with mobilization of the extremity, with physical therapy, whether they do well with sympathetic blockade, peripheral nerve blocks, how the patients do with oral analgesics, how they do with adjuvant analgesia, such as gabapentin and pregabalin and medications such as that. Oftentimes, multiple agents are required pharmacologically to control the pain, a series of sympathetic blockades, and physical therapy. So when we look at the patient under treatment for complex regional pain syndrome, initially, psychological treatment and support is important. Physical therapy is important. Appropriate medication management is important. And again, sympathetic blockade, peripheral nerve blocks, beer blocks, and so forth may play an important role. Where we go beyond that depends on the progress the patient shows. Those patients that fail to progress are considered for other more advanced pain management techniques such as intrathecal pumps, spinal cord stimulation, peripheral nerve stimulation, so forth. There is a percentage of patients who unfortunately do not respond and go on to chronic pain management, physical therapy, and unfortunately disability. And then ultimately, as end line in severe cases, neurodestructive techniques such as gangliotomy, rhizotomy, surgical sympathectomy, and so forth can be considered. So the treatment is based upon patient response. I mentioned earlier that there are multiple proposed etiologies for complex regional pain syndrome, and at times the therapies can be directed at these etiologies. So depending on how one perceives the various factors as being operative in particular patients, the therapies are adjusted accordingly. I would suggest that the role of the podiatrist initially is that of diagnosis and referral. However, I have always personally actively participated in the management of complex regional pain syndrome together with physiatry or neurology or pain management, whether it's peripheral nerve blocks or pharmacologic therapy, assisting in physical therapy, anti-inflammatory therapy, and so forth. So one can choose to not participate at all and to refer these patients out for total management, or one can participate in the therapy. With regard to pharmacologic therapy, there are many approaches that can be taken in these patients, and it is very difficult to tell from patient to patient what is going to work. My own experience is that pharmacologic agents as an isolated therapy is likely to be unsuccessful. You've got to combine this with psychological therapy, physical therapy, and pain management in the form of sympathetic blockade or other interventions. There are some patients in whom corticosteroid therapy is helpful. There are some patients in whom anti-inflammatory therapy with standard NSAIDs is helpful. There are some patients that do well with peripheral nerve blocks. There are some patients that do well with topical compounded medications. Some patients do well with adjuvant analgesics, such as tricyclic antidepressants or serotonin or epinephrine reuptake inhibitors. Some patients do well with anticonvulsants, such as gabapentin or pregabalin. And then there's the issue of osteopenia with the use of bisphosphonates or other agents to try to interdict the progression of osteoporosis. There are also some authors who have suggested that high-dose vitamin C therapy may be helpful. So some of the typical medications that we might consider as podiatric physicians would include tramadol, nortriptyline, pregabalin, duloxetine, mexiletine, and topical lidocaine, either as a patch or a gel or as part of a topical compounded medication. Vitamin C prophylaxis has been suggested at a dose of 1,000 milligrams daily for the prevention of complex regional pain syndrome. When allodynia does not prevent its use, I personally have found that compounded medications administered topically are frequently very helpful. I always will include some type of local anesthetic, typically 5% lidocaine, although other topicals, bupivacaine, tetracaine, can be utilized. Topical ketamine, clonidine, gabapentin. One can utilize tricyclic antidepressants such as nortriptyline or amitriptyline. If the patient is in a vasoconstrictive mode and you want to try to achieve some vasodilation, then topical calcium channel blockers such as verapamil, nifedipine may be helpful. And again, if you feel there is an inflammatory component to the patient's etiology, one can incorporate topically an anti-inflammatory. And although topical compounded medications are typically more expensive, it does give us the ability to utilize multiple medications to hopefully provide the patient, number one, with pain relief, but then number two, looking at the stage that that patient is in, and then adding whatever multiple agents we feel might be appropriate to address the multiple mechanisms that are operative in any particular patient regarding etiology. With regard to our referrals to interventional pain therapy, they can administer a variety of therapies to our patients that range from minimally invasive, such as transcutaneous nerve stimulation, to very invasive, including spinal cord stimulators, or as mentioned earlier, gangliotomies or rhizotomies, or other nerve destructive lesions. As a podiatrist, we can certainly participate with peripheral nerve blocks, with the administration of beer blocks. I've done that in my lifetime on multiple occasions, and we can certainly assist with, for example, the use of the transcutaneous nerve stimulators. So these are some of my patients who have had complex regional pain syndrome, and I will go ahead and administer ankle blocks to these patients. Utilization of beer blocks was described by Poplawski. It's a technique that I will typically utilize. We will use a double cuff technique because we're going to be using as much as 200 milligrams of lidocaine intravenously. You want to make sure there's no preservative, of course, in that, and we'll combine this with 80 milligrams of Solumedrol. And we want to have a double blood pressure cuff because if we lose our tourniquet accidentally, we can have sudden release of a rather large dose of amide anesthetic, and this can have, of course, significant cardiovascular implications. And if we can identify specific nerve injuries, we can work together with pain management or neurology or physiatry, make sure the patient is appropriately covered, utilize regional nerve anesthetic techniques, and go ahead and perform a neurolysis or neurectomy of the involved nerves that we think are responsible for the complex regional pain syndrome. Unfortunately, there are some patients that have pain that goes unrelieved and underwent amputation. Physical therapy and occupational therapy. Here again, there are a variety of therapies that are available for these patients, and oftentimes we will administer peripheral nerve blocks, beer blocks, utilize TENS units together with physical therapy and occupational therapy to reduce the patient's pain, to enable them to go through their therapy. My own personal experience has been with, at least with pain management, that really the recommendations they tend to make are more general once you get beyond the specific pain intervention, and oftentimes they will abrogate their responsibility to the more peripheral therapies to the podiatrist, which is fine as long as you're willing to accept that responsibility. A number of psychological therapies are also documented as being effective for patients with complex regional pain syndrome. Again, it's unfortunate that not all of these therapies are universally effective from patient to patient. I have seen some studies that indicate that up to 40% of patients who develop complex regional pain syndrome have some pre-existing psychiatric diagnosis. There are other papers that dispute this, but oftentimes we see that the patients who do develop complex regional pain syndrome do have a prior history of some psychosocial problems, interpersonal relationship problems, anxiety, depression, or other psychological problems, fibromyalgia, and a number of other issues. I don't think this is at all uncommon in the patients that do go on to develop complex regional pain syndrome. Now, that's based on my personal observation and my understanding of the literature, but again, there are some papers that would certainly dispute that. Some of the therapies that are typically utilized, bisphosphonates are helpful for decreasing pain and swelling and increasing range of motion, and importantly, diminishing the rate of bone loss. So I will frequently utilize bisphosphonates either orally or by intravenous or injection. Calcitonin, the evidence really does not support its use. I will say that personally, I found calcitonin has been helpful, or I think has been helpful for some patients that I prescribed it for. Calcitonin is helpful not only for interdicting bone reabsorption, but also does have some analgesic properties. Oral steroids, if given in an adequate enough dose, are frequently helpful, particularly during the acute stage, the initial stage when the patient is vasodilated. Gabapentin and pregabalin are said to have marginal benefit. Here again, I think one of the major issues is whether or not this drug is given at an adequate dose. You have to be certainly careful for observing these patients for neuropsychiatric side effects. But my own experience with gabapentin and pregabalin has been that it has been helpful orally. It is also helpful topically as part of compounded pain medications. Epidural and intrathecal clonidine have been shown to be effective for the treatment of complex regional pain syndrome. The literature seems to be rather unclear as to whether or not physical and occupational therapy are of benefit. Here again, I would say my own personal experience has been that it is a benefit, particularly when one can reduce pain sufficiently to allow the patient to participate in the physical therapy and occupational therapy. TENS units have been shown to be helpful, at least more helpful than placebo, and spinal cord stimulation certainly has been shown to be helpful. A number of newer therapies are being looked at and are available for the treatment of complex regional pain syndrome. I think the final problem is listed here. These are patients that have significant pain. Some of them develop lifelong pain. There are frequently disruptions in marriage and family relationships as a result of the chronic pain. These patients frequently incur large medical bills. Disability and unemployment is not at all uncommon. There are frequently associated financial problems because of the loss of employment and the mounting medical bills. And again, there is frequently a history of failed surgical intervention, failed successful treatment of injuries or prior care, and certainly loss of quality of life. So indeed, as my friend once said, complex regional pain syndrome is the best way to spend time with your malpractice attorney. It can occur without any inciting factor. As I mentioned, it can occur after a heart attack. It can occur after a stroke. It can occur after a DVT episode, and it can occur spontaneously for seemingly no reason at all. That represents the minority of cases, but this can occur. Typically, the problem is that there is an inciting event. Not infrequently, the initial signs and symptoms are consistent with that which one would expect following that initial event, meaning a fracture, post-operative status, so forth. So the biggest problem, again, is a failure to recognize the disease. Not that this is negligence on the part of the doctor, but we really have non-specific signs and symptoms early on. When we recognize this, there is sometimes a failure to make an appropriate referral in a timely manner. And here again, I would suggest that oftentimes this is because there are other explainable reasons for the patient's signs and symptoms. There may be a failure to appropriately treat the patient. So complex regional pain syndrome is indeed a problem. It is not at all that rare, and hopefully this review will be of benefit to you in thinking about the evaluation and treatment of patients with complex regional pain syndrome.